Assalamu alaikum. It's Dr. Abid Rafiq Chaudhry here. Uh, I am pediatric intensivist at Fatma Memorial Hospital, Shadman, Lahore. Today topic is shock physiology and role of inotropes, vasodilators and vasoactive agents in pediatric ICU. So nothing to disclose. There is no conflict of interest. So first of all, the objectives for this presentation, we need to discuss about the factors uh, central to oxygen delivery and cardiac output. Also, we need to learn physiological and lab parameters to guide about shock therapy, and also we are going to discuss about the reasons behind physiological reasons behind PAL shock management guidelines, and also we'll quickly review about different types of inotropes and the vasoactive agent which are commonly used in pediatric. So what's the definition of shock? Shock is a mismatch of supply and demand in a patient. So we know that oxygen delivery, it is important for uh, 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 oxygen delivery is the main, which is the cardiac output, and into the oxygen content. So it's a systemic flow QS into the oxygen content, that how much good quality of blood we have, and VO2 is the oxygen consumption by the tissue. So any mismatch between these two, we call it the shock. Normally, there is 5 times more oxygen delivery as compared to the oxygen consumption. In the next slide, we'll see. Here you can see, I mean, in this slide, you can see that on the x-axis there is oxygen delivery, and on the y-axis there is oxygen consumption. So normally we know that oxygen delivery matches with the oxygen consumption, and it is almost in a normal patient 5 times more. Oxygen delivery is 5 times more. But as the shock progress, and this is the mixed venous saturation, which is like normal 75 to 80. Anything less than 70 is a shock. So as the shock progress, the mixed venous saturation is going to drop, and you can see here it is 50%. And because what happens once there is a decrease of cardiac output flow to the body, any organ, then the tissue oxygen extraction going to increase. So I mean, you can see here the oxygen consumption is like 4 ml per kg per minute, and normal delivery is 15 ml per kg per minute. So like it's a 3 and 15. So it is a 5 times more delivery as compared to the as compared to the oxygen consumption in a normal state. But as the shock progress, then it's a supply dependent metabolism, and the shock progress like this, because there is a decrease in oxygen delivery, and once it goes like less than like 5, and then there is a decompensated shock, and obviously then oxygen consumption has been compromised. So I mean, this is very important relation which we need to keep eye while we are managing these patients in pediatric ICU. So I put this slide just to remember that what is the normal RA pressure in a child like 2 to 6, and also you can see the LA pressure is like 5 to 10, and systemic pressure systolic is like around 90, and 65 is the diastolic, and CVP is normal in 2 to 6 in a child. So these are the normal intracardiac pressures. So the types of shocks, there are different types of shock. We know that when it can be hypovolemia, mostly because of the diarrhea in the developing world. Cardiogenic can be because of myocarditis in pediatric patients, and septic shock can be distributive, especially in older children. Other than it's you know. Uh, so if once it is distributive, it because the tank has been dilated, so obviously the blood pressure is on the lower side, and the mixed venous saturation also on the lower side, and urine output is decreased, and lactate is trying to build up above 2. So these are the three parameters. Other than the clinical parameter, we need to keep eye. Mixed venous saturation above 70. If it is less than 70, patient has developed shock. Lactate is more than 2, and urine output should be around 2 ml per kg per hour. But if it is less than like 1 ml per kg per hour, so definitely it's oliguria. The other type of shock is anaphylactic, and obstructive shock can be in pediatric patient because of pericardial tamponade, especially in pediatric cardiac surgery patient, or it can be even in a small baby because of pneumothorax. It can lead to the obstructive shock. So, I mean, in this cartoon, we can see that, we know that cardiac output is equivalent to heart rate and stroke volume. And if this is the heart, I mean, you can see how big is the pound, which corresponds to preload uh, in the patient. So this is the preload, this is the heart, and you can see these are the peripheral blood vessels which are representing the SVR, systemic vascular resistance. So obviously the heart has to pump against this afterload. So these are the three components of the stroke volume, which is preload, contractility, and this is afterload against which the heart has to pump blood into the aorta. So cardiovascular physiology, it all depends. Depends on the Ohm's law, because it depends on the physics rules. So we know that one, that according to Ohm's law, the Q is the flow here. So any flow in a like tube, it depends on the pressure gradient. If there is no more pressure gradient, obviously the flow is more, and it is inversely proportional to the resistance in that tube. And according to the law of Laplace, especially in terms of the afterload, we know that one, it depends on the transmural pressure across the chamber directly, and also to the radius, and it is inversely proportional to the thickness of the tube. If the tube thickness is bigger, then the resistance is low. And oxygen extraction ratio, we know that one, it is the mixed venous saturation like VO2 over DO2, and normally you calculate in a pediatric ICU with this formula. And we know that when oxygen delivery is equivalent to cardiac output into oxygen content. So this is the amount of blood, and this is the quality of blood, how much good quality of blood is going to the tissue. Means how, because this equation is very important, because in some time if you cannot optimize the cardiac output, maybe you can optimize the oxygen content by better oxygenation ventilation, and by giving PRVC, especially in a cyanotic heart disease patient, to fix the oxygen delivery time being in pediatric ICU. This is the equation I put for the the fellows. So oxygen delivery is basically heart rate into stroke volume, which is your QS, like the cardiac output into 1.34 hemoglobin into saturation, plus PO2 into 0.003. So that's normal, around like 500 ml per minute is delivery of oxygen in any patient. So according to physics, as we discussed, the flow depends on the pressure gradient, and it is it has a inversely proportional to the resistance in any tube. And if we put this equation like this, the pressure is equivalent to resistance directly, and also it depends on the flow. So basically, resistance is the SVR, and flow is the cardiac output, and this is the mean arterial pressure in any patient. So this is how it comes. So a lot of times while we are fixing the mean arterial pressure, remember, maybe pressure is high, but the cardiac output and oxygen delivery is low in that patient, because body try to compensate by increasing the SVR, by having endogenously catecholamine. So high blood pressure does not mean there is a better oxygen delivery. So that is the reason we talk about a lot of times. Maybe you can have a low blood pressure, like in myocarditis or any other cardiac problem, because then you end up by having a better afterload, reduced afterload, and maybe your cardiac output and oxygen delivery uh, is better. Having said that, pressure is on the lower side as long as you are passing urine. So this is very important physiology we talk about in pediatric cardiac ICU, that don't go for higher pressure. As long as you're passing urine, you're clearing lactate, baby is passing urine and mixed venous saturation is above 70 in a fully corrected heart, you are good. Or in a not in a fully corrected heart, like in cyanotic heart disease, maybe the arterial and venous mixed venous saturation difference should not be more than 20. So that is important, especially if you are dealing with the cyanotic heart disease patient in pediatric cardiac ICU. But having a patient good blood pressure does not mean anything. We are talking more about urine output, mixed venous saturation, and lactate. So as we discussed before, cardiac output is equivalent to. So a lot of times, a patient, they build the heart rate to maintain the cardiac output, but ultimately we need to work on the stroke volume, which is preload, contractility, and afterload in. So if you how we try to optimize every time in the pediatric IC or cardiac IC the stroke volume by optimizing the preload. Once the preload is optimized, then you have to work with the contractility by giving inotropes, and also with the vasodilator you have to manipulate the afterload, especially in cardiac patients. So what is venous return? It is the degree to which the myocardium is stretched before it contracts. So and it depends on the blood volume and the venous capacitance, in other words. In this diagram, I mean, there is a relation between cardiac output and venous return. On the y-axis, there is a right atrial pressure, and the like x-axis, and there are y-axis, there is a cardiac output. So if you can see, if you give volume and there is a decreased venous compliance, ultimately your cardiac output is increased in these patients. But if for some reason there is a decrease intravascular volume or increased venous compliance, then you have less cardiac output in this area. So as these are the pressures, and if there is a less pressure in the right atrium, obviously there is a more venous return to the right side of the heart, and there is a better cardiac output. So this is how you can see there is a cardiac output you can generate better by having more negative pressure in the right atrium. And if you increase inotropes or give decrease afterload by giving vasodilator, also your cardiac output is increased. And for some reason, if there is a decrease inotrope or increase afterload, then your cardiac output is going to drop. So the most important thing here, that more your atrial pressure they are on the lower side, the more better venous return, and the more heart is happy, and the better cardiac output you have, and the better oxygen delivery you have in that patient. So, in this picture, we can discuss about the relation of the heart with the afterload. I mean, we know this is the preload and this is the heart, but for some reason, if the heart contractility decrease, like in myocarditis, then you don't have any option, because your preload, if you are optimizing preload in myocarditis, although it does work, but ultimate which things work is a vasodilator. But because once there is a decrease contractility, then the best option to have a decrease afterload in these patients by giving vasodilator. And you see, because then with the decreased contractility, it is easy for heart to eject blood in the in systemic vascular resistance. If it is low, then it is easy for the heart to eject, and better cardiac output and better oxygen delivery. So, in other words, afterload is the resistance against which the blood is expelled, and it is very important to know that relation, that you have to keep decreasing the afterload in a patient who has a decreased myocardial contractility like myocarditis. So quickly we can define what is inotrope: agent that improves myocardial contractility and enhances stroke volume, you have dopamine or epinephrine. Vasodilator: agent that reduces systemic vascular resistance and reduces afterload on the heart. So in other words, decreasing the SVR like you have dobutamine, and recently in the last 10-15 years, milrinone has almost replaced the dobutamine, because dobutamine causes also tachycardia, and also added advantage of milrinone having a lusotropic effect. We'll discuss in a couple of slides next, that it give you the better oxygen delivery, also optimize in the heart myocardial circulation. So definitely milrinone also does not give you tachycardia, which dobutamine give you, especially in higher doses above like 7 to 10. So milrinone is excellent drug, which has almost replaced in the last 10 to 15 years dobutamine, even in developing world. Inodilator agent that increases cardiac contractility and simultaneously reduces systemic vascular resistance to reduce cardiac workload by increasing stroke volume and decreasing SVR. So in this example, you can see here, you have decreased the systemic vascular resistance, then it is easy for heart to eject blood, and leading to better cardiac output in any patient, especially in cardiomyopathy or myocarditis patients. So for some reason, this is the example where if tank is dilated, then maybe by giving vasopressor, you can shrink the tank and you can have a better mean arterial pressure. So the agent which are vasoconstricting the systemic vascular resistance, they call it vasopressor. And also they are very important, like epinephrine and norepinephrine or vasopressin, depending on the patient how much they need to constrict their peripheral vascular resistance in a shock patient, especially if they have a warm shock, like distributed shock in older patients. So we discussed that vasopressor is the agent that increases systemic vascular resistance and increases blood pressure and ultimately lead to high SVR. So lusotropy is a very important, properties which the milrinone possess. So it is basically a diastolic relaxation and keeping the heart happy while the heart is doing work. And that is the main advantage of milrinone versus dobutamine, that milrinone has an excellent lusotropic effect, and it has also at the same time as sometimes dobutamine can increase the myocardial oxygen consumption demand if the heart is very much tachycardic. Milrinone does not cause tachycardia, and it is an excellent stroke volume. It increases stroke volume, so it's inotropes, and also very importantly, it is a vasodilator. At that same time, it also increases the myocardial, perfusion in the coronary vasculature and leading to the diastolic relaxation. And that is very important property of milk. Uh, so improves cardiac function by promoting diastolic relaxation and hence ventricle filling and increase in stroke volume. That is the function of milrinone. So uh, once you how to establish a shock diagnosis, it is mostly clinical, and they are tachypneic, tachycardic, they might have low blood pressure. Narrow pulse pressure is very important, and you can see if you have arterial line, it is very important. Slow capillary fill time, more than 3 seconds, weak peripheral pulses, and possible you have a decreased urine output, and also decreased level of consciousness. The most important thing which we have seen clinically in these patients, shock patients, the most important thing in these patients, if you check the mixed venous saturation, that is less than 70%, because the oxygen extraction has been increased. Having said that, there is a decrease. We know that when the shock is a mismatch between oxygen delivery and oxygen consumption. So once there is a decrease in delivery, ultimate tissue try to extract more oxygen, and then there is a decrease in the mixed venous saturation, which is returning back to the heart from the tissues. So this is less than 70, and that is the earliest point in early shock to pick, because a lot of times lactate and urine output, they are the later signs. Lactate try to build up later on, and urine output drops later, before after the shock established. So mixed venous saturation is very good guide to pick the shock patient early. These are the things which I have learned over the years in pediatric cardiac ICU, and I have learned from pediatric heart surgeons. Like they come and they check the temperature gap. which is the temperature gap should not be more than 3, and that is a gap between central and peripheral temperature. One temperature central is in the rectum, the other one is the peripheral temperature, and both things you put on the monitor, and the nurses, they are documenting the peripheral and central temperature. If the gap is more, like more than 3, then you have a problem. Urine output, if it is less than 1, you have a problem. Mixed venous saturation like 65, 60 is not good, and lactate is building up. Especially the trend is very important. If mixed venous saturation is dropping, urine output is slowly going down, and lactate is going up, you have a problem. So these are the three important things which we also monitor other than the diagnosis. Also, once we start patient on inotropes or preload optimization or afterload optimization, these are three things we have to monitor in a shock patient: urine output, mixed venous saturation, and lactate. So these are the important markers, even when to wean inotropes. Once you control the situation, and once you have stabilized your patient. So these are the tools also to monitor the weaning of inotropes in pediatric ICU or pediatric cardiac ICU. Physiology of causative factors, it is very important, and whenever I encounter any problem in pediatric cardiac ICU, there are 7 factors. If the patient has a low cardiac output, this slide is very important. You have to go stepwise and look at, because these are the 7 factors which can lead to low cardiac output in pediatric ICU or pediatric cardiac ICU patient. So number one, you have to optimize the preload, and also you can check the pulse variability, on arterial pulse. So whether it is a volume responder or not, other than the just CVP number, one number is not important. The trend is important, especially the CVP and the arterial, the pulse variation, especially variation on the respiration and ventilator. After load, you have to optimize. If you have optimized the preload, maybe you have to work with a vasodilator like milrinone. Contractility, obviously, you have to work with the stroke volume by giving dopamine, epinephrine, or milrinone, depending on your patient. And these are the three things. So if you have optimized and still the patient has a problem, then you think about obstructive, the physiology. So what is the right-sided obstruction? Right-sided obstruction, is the basically they may have like pneumothorax or pericardial tamponade, and the left-sided problem obstruction to the left side of the heart is your pulmonary hypertension. So you have to keep in your mind, because there is no left-sided preload if the patient has pulmonary hypertension, especially if you are dealing patient with a status post VSD closure or endocardial cushion defect or truncus arteriosus. So keep in mind they have a no preload to the left side of the heart. They are obstructed because they have a pulmonary hypertension. So it is very important. So you have to deal with the pulmonary hypertension. Obviously you will hyperoxygenate, hyperventilate, and you may have to sedate and paralyze the patient. Maybe you have to keep on ventilator couple of days before you extubate these patients. So obstructive here, mostly you have to keep in mind the like pericardial tamponade and the pneumothorax, especially in small patients. And if you have optimized everything, maybe patient has a residual lesion and the repeat echo, and convincing the surgeon, especially if you may have like a residual VSD in a tetralogy FLO, which is causing low cardiac output. So think about that. Maybe the job has not been done appropriately in the cardiac OR. If you have dealt everything, then the most important thing, another one, I have learned in ICU, you have to keep eye on the intra-abdominal pressure. So if your shock is not improving, maybe the IVC is obstructed because of tumor or because of high intra-abdominal pressure. Lot of times in a small patient, you put a peritoneal drain and leave a drain to gravity, and they start passing urine. So very important in a cardiac ICU, if you are dealing with low cardiac output and you have to optimize everything, and patient is not improving, then think about intra-compartment syndrome, intra-abdominal compartment, because they have a leaky fluid in the abdomen and they behave like an intra-abdominal compartment. You can even measure intra-abdominal pressure. There is a way to do that one. And also, once you put a peritoneal drain in these patients, You don't have to do peritoneal dialysis, just leave the drain to the gravity, and they start passing a lot of fluid, and after like 3 to 4 hours they start passing urine also. So this is very important to keep in mind. Also, another important thing in a cardiac ICU, if you are dealing with a low cardiac output, think about the rhythm issue. Like they may have a block or they may have a jet. So keep these things in mind. And last but not the least, most important thing, obstructed venous return. So if you cannot fix the patient in cardiac ICU, then think about maybe the veins are obstructed. This is very important thing if you are dealing in a patient, because if there is no venous return, there is no cardiac output. So physiological parameters to guide therapy. We discussed before, heart rate is important, especially if they are tachycardic and to begin with, and now tachycardia is improving. That means your shock is improving. Blood pressure is important, but the most important thing in the blood pressure is your pulse pressure. And by just looking at the arterial wave, you can see how good is your cardiac output, because area under the curve is your stroke volume. Capillary refill time is important, temperature gap is important, pulses are, they are very important, sensorium is very important, especially if your patient is improving urine output, as we discussed before, other than the mixed venous saturation and lactate. Lab measures to see response in your lactate and mixed venous saturation, especially if you have intracardiac lines or you have a CVP, then it is very reliable and should be more than. So, what are the gold standard? What we have learned over the years in pediatric or pediatric cardiac ICU, the most important thing we know in these patients is the bedside presence of intensivist. Because if you spend some time with your patient, and you will figure it out why your patient is having running low, cardiac output syndrome. So you need to know your patient, and obviously then you troubleshoot according to the trends you are facing right now. So how to choose among the inotropes, vasopressor and vasodilator? Actually, it's very simple. Just need uh, a couple of years of practice in pediatric ICU under guidance, and then you will come to know what you need to do in these patients. But there are physiological reasons, and that you have to learn practically at the bedside. But the most important thing in any patient, whenever I mostly don't much rely much on dopamine, even in pediatric ICU or cardiac ICU, more rely with epinephrine, low dose like 0.03 microgram per kg per minute, and if the blood pressure is okay, then maybe you can add later on with milrinone, especially if you need like little bit vasodilatation. So this is a combination, and normally I don't give bolus. We used to start milrinone with like zero point 0.3 to zero point 0.5 micron per kg per hour. So I put for here the pulse haptic shock algorithm. Obviously, initially you recognize the decreased mental status and perfusion. You start giving high flow oxygen, and you establish the IV assess. And if there is no hepatomegaly and rails, and you can start with isotonic fluid like 20 ml per kg and reassess after each bolus. Uh, you know, uh, uh, until the improved perfusion. But now there is a recent guidelines. You can keep assessing the patient, and at the same time, also you have to correct hypoglycemia and hypocalcemia. Calcium is very important, and obviously think about giving antibiotics in the newborn. Prostaglandin need to keep eye that maybe you are dealing with obstructive shock like obstructed venous return. If the shock is fluid refractory, then you have to think about starting inotropes and preferably epinephrine, as we discussed before. And obviously, once you start inotropes, then you have to keep thinking about taking a center line and also putting arterial line, especially if you are building up more inotropes. Then you have to titrate epinephrine, and the next inotrope or vasopressor depend on what you are dealing with the patient. Especially if your blood pressures are okay, we prefer to put milrinone. But if you have a warm shock, your pressures are low, then obviously a norepinephrine or norepinephrine is good, especially with 0.03 microgram per kg per minute. But especially if you establish that you are dealing with a catecholamine resistant shock, then you think about renal insufficiency and consider giving hydrocortisone. And then also at the same time, you have to use your other methods, including like PICO, especially if available, not available in Pakistan. but outside we were doing with the lidco and also Doppler ultrasound to assess the fluid responsiveness and other measures to see the cardiac output in the patients. So goal, as we discussed before, is the saturation, mixed venous saturation should be 70. Cardiac output you have to optimize around 3.5 liter per minute per meter square, and lactate need to clear out less than 2, and urine output has to be optimized. So the next all depend on in a septic shock patient whether you have a normal blood pressure or low blood pressure. If you have a normal blood pressure and cold shock, your saturation is less than 70, hemoglobin is fine, and you are on epinephrine, and then in these patients with normal blood pressure, you can begin with milrinone, to have some effect of vasodilatation, vasodilator, and increasing cardiac output. But if you have already low blood pressure in a cold shock and less than 70% is your mixed venous saturation and hemoglobin is okay, and you are on epinephrine, then maybe here you have to put a little bit of norepinephrine and titrate the effect. But in a warm shock patient where you have already low blood pressure, mixed venous saturation is more than 70, and you are already on norepinephrine or epinephrine, then maybe in these patients you can try the vasopressin, but keep eye on the side effect of these drugs. And at all these patients, in all these patients, you have to think about giving hydrocortisone, and in some patients also thyroxine does work, other than ruling out that whether you are dealing with any obstruction in the venous return, as we discussed before, like intra-abdominal compartment or pulmonary hypertension or pneumothorax or pericardial tamponade. So if the shock is not improving, think about that venous return. There is a problem in the venous return. And obviously, we discussed that the intra-abdominal pressure has to be around less than 12. So these things are very important in any patient where your shock is not improving, as we discussed before. So things to remember in a shock patient, the cortisol we discuss. Also, a lot of times we give them calcium because it's a good ionotrope. Even cardiac ICU, we put them on drip, especially the newborns. They're very sensitive. We know that their myocardium is very sensitive to calcium, and we use as a ionotrope also. So also in small babies, thyroxine does work, and a lot of, especially in North America, in a single ventricle physiology after an Norwood procedure, a lot of time we were giving all these three things in patient who has refractory low cardiac output syndrome, especially in a newborn. So also you have to keep eye on the ID. So you have to optimize your antibiotics and keep eye on the newborn. They are very easy to deteriorate, and sometimes you have to if you are dealing with low cardiac output syndrome and heart is swollen, maybe you have to open their chest if they have a chest closed. This is very important thing to remember, and treat the primary cause. Why I have written here, treat the primary cause. So you need to know what you are dealing. You are dealing with the preload contractility or afterload problem. You are dealing with obstructive shock like pneumothorax or pericardial tamponade. You are dealing with pulmonary hypertension. You are dealing with a rhythm issue, or you are dealing with a residual lesion in a patient. So you need to know your patient and then treat the primary cause to reverse the low cardiac output syndrome in a cardiac patients. So how you can optimize, shock? We know that is a mismatch. So if you cannot improve the delivery, maybe for some time you can decrease oxygen consumption by controlling the fever and shivering, by sedate and paralysis to reduce the agitation, and also by paralysis by reducing the so, quickly about the ionotropic and vasoactive agent used in the pediatric ICU. We know dopamine has a vasopressor effect other than the inotropes. Dopamine are almost obsolete now in cardiac patients. Milrinone has been replaced with, and epinephrine is the first choice for any patient with low blood pressure to begin with for us, and it has excellent effect. It is ionotrope, vasopressor. It has a also it increase the chronotropy other than the inotropes, and even it has a dromotropic effect. And milrinone is definitely has replaced the dobutamine, and it's excellent drug, especially in cardiac patients. So further, we can discuss quickly about the effect of these drugs on the different receptors. We know phenylephrine has a potent effect on alpha 1. It does not have on effect on other receptors, and these are the clinical effect. Norepinephrine strongly has a alpha 1 effect, including the epinephrine. Epinephrine does have also beta 1 and beta 2 effect, mostly which you especially use in asthmatic patient. So regarding the rest of the drugs, they are not much promising in pediatric. So we know that one alpha one effect is mostly vasoconstriction, and norepinephrine has the highest effect. Later on, having uh, epinephrine, and the least one is by dopamine. Beta 1 has a ionotropic effect. Epinephrine has the most one, and obviously dopamine does have a strong effect. Beta 1, and dopamine has the least one. In terms of the beta 2 vasodilatation, especially in the lungs, epi has the most one. Later on, the dopamine and dopamine does have some effect. So important points: use after correction of intravascular volume. If you are using inotropes, ideally through central line and through a dedicated port. Vitamin milrinone can give through peripheral line, but remember milrinone has a long half life. Except milrinone has a long half life. Rest of the drugs, they have a short half life, like 2 to 5 minutes, and they are not compatible with bicarb. Vasopressor only through central line. Vasopressor exacerbation can cause gangrene, and norepi and vasopressin, they are the highest vasopressor. If you compare with the epinephrine. Improvement in organ perfusion. This is the goal for use of these vasoactive agents. So we discussed before the importance of better urine output, normal capillary fill time, warm peripheries, and improvement in conscious level. Other than the decreasing heart rate, from tachycardia, and improving blood pressure and decrease in base deficits. Other than the having a better mixing and saturation and lactate clearance. But the most important thing you need to remember, normal blood pressure does not mean a normal cardiac output. So you may have a better cardiac output and better oxygen delivery even with a low blood pressure, as long as you are passing urine and clearing your lactate and you have a normal. So okay, so now we can conclude. So we have a 2-year-old male child presented with fever and GI sepsis on exam, central pulses and peripheral pulses poor, tachycardia and hypotensive. So we have made the diagnosis of decompensated shock, airway breathing attended, oxygen by a non-rebreathing mask, and baby has received fluids. Follow exam still tachycardic and hypotensive. So you start with dopamine around 10, and after 30 minutes still tachycardic and blood pressure unchanged and cold periphery. So what will be your next choice? So you can start with adrenaline. So you have another patient, 6-month-old female boy brought by mother with a complaint of rapid breathing and cold periphery. Mother gives history of baby had excessive sweating while feeding. On exam, tachycardic, peripheral cold, and NIBP is 60/40. Tachypneic, increased work of breathing. Liver span is like 8 centimeter. Irritable cry. You have labeled the patient a cardiogenic shock case, and started the management in the form of face mask and small volume and slow fluid bolus. Started on divitamine or milrinone, and is the better choice in these patients. So you have another patient, 14-year-old boy, presented in ER with a history of high-grade fever, seizure, and loss of conscious level. On exam, GCS low, febrile, peripheral warm, and flushed. Heart rate is 140, NIBP 70/20. So you see here there is a wide pulse pressure and irregular respiration. So warm septic shock is a diagnosis, and most likely it is decompensated shock. So you have given simultaneously all like fluid, intubate, and epinephrine infusion on 0.1, which is quite high, and still you are struggling. So you have to put central line, and you have to start norepi in these patients because still the pressure is very low, especially there is a white. Important points to remember: oxygen delivery is a product of cardiac output into oxygen content, and oxygen content is a product of hemoglobin into saturation, oxygen saturation. We know that we have defined before oxygen content is also depend on the dissolved oxygen, other than the the oxygen carrying with hemoglobin, and that depend on the saturation how much is. So cardiac output equivalent to the heart rate and stroke volume, and a lot of times you have to work with the stroke volume in the form of preload, contractility, and afterload to improve the stroke volume, ultimately which increase the cardiac output and oxygen delivery. So pressure is directly proportional to the flow, and it is inversely proportional to the radius of that tube. Blood pressure, mean blood pressure is equivalent to it's the representative of your systemic vascular resistance and cardiac output. And normal blood pressure does not mean anything. You can have a normal blood pressure or even high with low cardiac output syndrome. So you don't have to treat your blood pressure. You have to treat your urine output, mixing and saturation, and lactate clearance. And we know that one, that you have to optimize sometime your stroke volume by giving. This is, I think, the last slide, and in which you can see once you have, congestive heart failure, on the y-axis there is stroke volume, and x-axis there is a left ventricle filling pressure. As the filling pressure is high, you may have a congestive and low output symptom, and with the diuretic, you cannot fix only. You have to add vasodilator other than the inotropes, and then you can stretch your cardiac output here, and you can improve your symptom. And if you add inotropes plus vasodilator, then you have a better oxygen, better cardiac output and better delivery, and your congestive symptom will improve. Thank you very much.